Today I'm going to be doing a presentation on congenital hypothyroidism, a literature review. For congenital hypothyroidism, I will also abbreviate it as CH. So for the introduction, congenital hypothyroidism is characterized by the inability to produce thyroid hormone at birth. Rose et al. 2023 reports that it occurs in approximately 1 in 2,000 to 1 in 4,000 newborns. It is more common in females. CH is the most common cause of preventable intellectual disability if detected early and treated promptly. So without treatment, infants can develop irreversible brain damage, growth failure, deafness, and neurologic abnormalities. So this is why newborn screening is essential, because it leads to adequate treatment that results in outcomes that are essentially normal. And then with early treatment, outcomes are essentially normal again. It's referenced by Max et al. 2019 and Rose et al. 2023. So for the objectives, I will explain the pathophysiology of congenital hypothyroidism and how it affects development, discuss the evaluation of CH, explore differential diagnoses and review red flags and immediate actions of CH, discuss diagnostic criteria and treatment goals, discuss research on CH, and review patient education, follow-up, and referral protocols for CH. So for pathophysiology, the fetus relies on maternal thyroxine for the first 20 weeks of gestation, but then it depends on its own thyroid function. In infants with primary congenital hypothyroidism, a defect in thyroid gland development called thyroid dysgenesis, or a defect of thyroid hormone biosynthesis called dyshormonogenesis occurs. The hypofunction of the thyroid gland usually causes low T4 and T3 levels, and then elevated TSH and elevated TRH levels due to feedback mechanisms to the pituitary gland and hypothalamus. So these effects, if they are left untreated, cause permanent CH. The condition can also be transient due to transplacental passage of maternal antithyroid medications, maternal thyroid blocking antibodies, or iodine deficiency or excess, as cited by Bowden and Goldis 2023 and Rogers 2023. So for common presentations, most infants are usually asymptomatic at birth, which is why screening is an essential step. When symptoms do appear, they may include large anterior and posterior fontanelles, prolonged jaundice, hypotonia, macroglossia, constipation, poor feeding, and then other symptoms that are listed on the picture to the left side and then also listed on the right side per Cabarez et al. 2025. Some severe cases may include hypothermia, lethargy, and bradycardia. So symptoms are subtle since maternal thyroid hormone partially compensates early on, but once again, they kind of show up later on throughout. So approach to the patient starts with newborn screening by obtaining a blood spot by heel stick. The newborn screening should be obtained after 24 hours of life, and it's recommended to be done between 48 to 72 hours, because if it's done before the 24 hours, it can lead to results that are false positive. So if the screening is abnormal, go ahead and confirm it with a serum TSH and free thyroxine. If the initial screening was normal, we want to perform the second newborn screening in 2 to 4 weeks of the newborn's life for patients who are acutely ill, are preterm, which preterm is defined as less than 32 weeks of gestation, if we have a low birth weight of less than 1,500 grams, if they received a transfusion before obtaining the newborn screening, if have a monozygotic twin, or multiple birth, or have trisomy 21. Also, again, do not delay treatment because delay can increase risk of permanent brain injury, and we also want to perform imaging and studies that are listed down below to determine etiology. Citations are from Rose et al. 2023 and Stupa et al. 2022. So for differential diagnoses, these are going to be from Domino et al. 2025, and they're geared towards adults initially, and these are including chronic fatigue syndrome, anemia, congestive heart failure, primary adrenal insufficiency. And the reason I included those is because it was a little difficult to find differential diagnoses specifically for CH, but I did find some differential diagnoses for CH from Bowden and Goldis 2023, which includes newborn screening that was obtained within 24 hours of life, and that can have an elevated TSH level due to post-delivery TSH surge in response to cold stress after birth. And then also this can lead to that false positive result that I discussed previously. So differential diagnoses for premature infants may also include hypothyroxemia of prematurity due to an immature HPT axis, also a secondary to central hypothyroidism or complicated by non-thyroidal illness. So this slide lists red flags that should prompt urgent evaluation and immediate treatment, and that includes lethargy, prolonged jaundice, feeding difficulty, microglossia, hypothermia, bradycardia, failure to thrive, and irreversible intellectual disability. And these are references from Cavazier et al. 2025 and Connelly et al. 2026. So here are listed actions that are immediate and non-urgent. So for immediate actions, that includes starting levothyroxine from 10 to 15 micrograms per kilogram per day. We want to go ahead and perform confirmatory labs. But immediate follow-up actions are based on the TSH levels of the newborn screening. So if the newborn screening TSH is greater than 40 MIU per liter, levothyroxine treatment should be initiated after drawing the confirmatory serum sample, and we just go ahead and do that without waiting for the results. But if the newborn screening TSH is equal to or less than 40 MIU per liter, we want to await the results of the confirmatory serum sample, and preferably to have that within 24 hours turnaround time, and also hold off on starting levothyroxine treatment. And this information is from Rose et al. 2023. So for non-urgent actions, that includes providing the parents with critical education regarding the etiology of CH, benefits of early diagnosis and treatment to prevent intellectual disability. We want to educate how to administer levothyroxine, what can interfere with levothyroxine absorption, such as iron, calcium, soy, and fiber, and also to adhere to the treatment plan. Long-term follow-up and follow-up, as indicated, are listed also in Table 1 from Rose et al. 2025. The comprehensive history should include family history of thyroid disease, maternal history of thyroid disease, also birth and term measurements. For physical exam, we want to include large anterior and posterior fontanelles, microglossia, the decreased muscle tone and delayed reflexes, respiratory distress, poor feeding, poor peripheral circulation, and in severe cases also cool and mottled skin. And references are from Max et al. 2019 and Stupa et al. 2022. Diagnosis is made through newborn screening between 48 to 72 hours of the patient's life. Newborn screening is abnormal and confirms primary CH if the TSH is elevated or FT4 is low. The table from Cavazier et al. 2025, as shown here, shows the diagnostic algorithm of congenital hypothyroidism after neonatal screening is identified. So we want to do treatment with levothyroxine, and imaging may also be done of thyroid ultrasound, scintigraphy of thyroid gland, radiograph of the knee, and renal and cardiac ultrasonography is optional. Management and treatment of CH must be started immediately once the diagnosis is confirmed or even suspected. So we want to go ahead and treat that patient with levothyroxine to replace the deficient thyroid hormone. And again, starting dose is 10 to 15 micrograms per kilogram per day, and higher doses are usually used in more severe cases. The treatment should begin no later than 2 weeks of life, as early initiation is associated with normal cognitive function outcomes. Higher doses may be necessary for rapidly normalizing serum TSH concentrations. So administer levothyroxine once a day orally at the same time every day. The levothyroxine can be crushed and mixed with 1 to 2 milliliters of water or breast milk. Educate the parents or caregivers to not administer levothyroxine at the same time as calcium, iron, or soy, since these impair absorption of the levothyroxine. TSH levels must be maintained within the normal range for the first year of life, so that is the most essential time period for the patient. And then adjust levothyroxine dose depending on these lab values that are obtained. And then long-term management involves ongoing monitoring and dose adjustment as the child grows, with the main goal of ensuring normal growth, development, and neurocognitive outcomes similar to the infant's genetic potential. References of Bowden and Goldis 2023, Cavazier et al. 2025. So here is treatment options. So treatment is levothyroxine given once again orally 10 to 15 micrograms per kilogram in infants a day, and that is for infants that are 0 to 3 months, and the dose may be increased after 4 to 6 weeks to 50 micrograms daily. For infants that are less than 2,000 grams or are at a risk for cardiac failure, give 25 micrograms daily. Also, another treatment option is liothyronine synthetic T3G cytomel of 5 micrograms daily and increasing in increments of 5 micrograms daily every 3 to 4 days until the desired response is achieved. And then a maintenance dose for infants a few months old is 20 micrograms daily. References are Wu and Robinson 2020. So here is my research slide. Research was done for the comparison of permanent congenital hypothyroidism and transient congenital hypothyroidism. Primary CH had higher TSH levels and required higher levothyroxine doses compared to transient CH, which required a smaller dose of levothyroxine. Also, permanent CH requires lifelong levothyroxine treatment, while transient CH only needs temporary treatment, as identified by the current newborn screening program by Cow et al. 2025. So for the studies, here's a chart on mild CH. Mild cases rose by 0.069 per 10,000 per year, and their share of all CH diagnoses increased by 0.89 percentage points annually, which is shown here in figure 4 on the slide from Grobe et al. 2025. So basically what this means is it indicates there is a less severe disease presentation. So instead of like a lot of high, intense, severe CH, we have more mild CH shown, which is good because it means the shift went from a severe symptomatic CH to more mild CH due to early detection and treatment. So for patient education on the diagnoses of CH, we want to discuss the importance of early diagnosis and treatment to prevent poor neurodevelopment outcomes. Remind them for daily medication adherence and to do it at the same time is critical. Educate that medication, once again, adherence is important, and we want to administer it on an empty stomach for better absorption. Also, avoid mixing with interfering substances of iron, calcium, soy, and fiber. Educate on the importance of close follow-up visits and thyroid lab monitoring. Included is a fact sheet to give the families for congenital hypothyroidism if you click on the link. And then references are from Bowden and Goldis 2023 and Pediatric Endocrine Society 2020. So for the follow-up, the first repeat thyroid function test includes FT4 and TSH to be drawn at 1 to 2 weeks after the start of levothyroxine therapy, with a follow-up TFT every 2 weeks until a complete normalization of TSH. Then repeat that TFT every 1 to 3 months until the age of 1 year. And then children should have follow-up visits with TFT obtained every 2 to 4 months between the ages of 1 to 3 years old. And then every 3 to 12 months until growth is completed. And then so throughout these follow-ups and repeat tests, adjust the dose as needed and monitor growth and development. References of Bowden and Goldis 2023. Referral. The infant should see physician if the infant has a low TF and elevated TSH. Refer the infant to a pediatric endocrinologist for diagnostic evaluation and optimal management. Referral is essential for severe hypothyroidism of a very low T4 and elevated TSH, and a delayed diagnosis of more than 2 weeks of life. References are from Rose et al. 2023. So in conclusion, congenital hypothyroidism is commonly caused due to an embryologic defect in the thyroid gland development or defect in thyroid hormone synthesis. Early detection and treatment is essential. Presentations may include constipation, lethargy, feeding problems, hoarse cry, microglossia, hypotonia, and jaundice. Diagnostics of newborn screening. And once again, we want early detection and treatment because this is essential. For patient education, we want to provide education to the parents and caregivers on levothyroxine treatment. And then for repeat testing, repeat thyroid function test in 1 to 2 weeks after the start of levothyroxine therapy. And here are my references that are listed. Thank you for watching my PowerPoint.